The human heart ejects roughly 5 liters of blood per minute at rest. When we exercise, our muscle tissues demand massive increases in local flow. If the body suddenly widens every blood vessel at once to meet that demand, systemic pressure instantly plummets, starving the brain and heart of oxygen. Ohm's law defines blood flow as the pressure gradient divided by vascular resistance. Poiseuille's law reveals the components creating that resistance. Combining these equations highlights the functional control mechanism, raising vessel radius to the fourth power. Doubling an arteriole's radius increases local flow 16-fold. To maintain perfusion during heavy physical exertion, the body doesn't need to generate massive amounts of new blood. It relies on making microscopic, highly coordinated adjustments to arteriolar radius to instantly redirect flow exactly where it is needed, without crashing systemic pressure. This graph illustrates the functional autoregulatory plateau. It shows that individual organs maintain a highly consistent blood flow, represented by the flat plateau on the curve, as long as mean arterial pressure stays within the limits of 60 to 140 millimeters of mercury. Two local mechanisms maintain this plateau. The myogenic response physically constricts vessels when high pressure stretches their smooth muscle walls. Conversely, the metabolic response chemically dilates vessels when local oxygen falls and waste products like adenosine and carbon dioxide accumulate. These flow time traces show how the body initiates vasodilation in two distinct patterns. The graph on the left maps active hyperemia, where flow elevates and sustains itself to match ongoing metabolic work. The graph on the right displays reactive hyperemia, producing a sudden, transient burst of flow specifically when a mechanical occlusion is released from a resting tissue. Confusing these triggers creates dangerous clinical blind spots. When physicians rapidly restore blood flow after an arterial clamp or a myocardial infarction, the sudden surge of highly oxygenated blood into ischemic, resting tissue generates a burst of toxic free radicals, driving severe reperfusion injury. This chart tracks left ventricular coronary blood flow. Flow drops near zero during systole because the contracting heart muscle compresses its own vascular supply. Perfusion happens almost entirely during diastole. In severe tachycardia, the diastolic window shortens drastically, robbing the myocardium of necessary oxygen and precipitating ischemia. The brain sits inside a rigid skull with a fixed maximum volume, dictated by the Monro-Kelly doctrine. To prevent catastrophic pressure spikes, cerebral vessels ignore systemic sympathetic nerves and strictly track carbon dioxide. Blowing off CO2 through voluntary hyperventilation triggers immediate constriction of cerebral arterioles, dropping perfusion and causing fainting. The lungs reverse the standard rules of perfusion. While systemic tissues dilate when deprived of oxygen, hypoxic pulmonary vasoconstriction actively constricts vessels near poorly ventilated alveoli. This mechanism physically shunts blood away from dead zones and redirects it toward oxygen-rich regions of the lung. Local survival overrides global consistency. The heart, brain, and lungs each abandon baseline hemodynamic laws to prioritize their specific metabolic and structural constraints. This flowchart maps fetal circulation. Because fluid-filled lungs present extremely high resistance, the system is wired in parallel. Oxygenated placental blood is routed through 3 anatomical shunts, the ductus venosus, foramen ovale, and ductus arteriosus, bypassing the lungs and liver. The postnatal transition relies on 2 events. The first breath triggers massive pulmonary vasodilation, dropping resistance. Clamping the umbilical cord spikes systemic resistance. Let's lock in the lungs, returning to the left atrium. Left atrial pressure exceeds right atrial pressure, physically slamming the foramen ovale shut. This single violent biophysical pressure flip completely eliminates the fetal parallel pathways, establishing the isolated series circuit that will operate for the remainder of the patient's life. Let's lock in the highest yield testable differences. Active hyperemia is driven by work. Reactive hyperemia is driven by mechanical occlusion. Systemic vessels dilate during hypoxia, but pulmonary vessels constrict. And left ventricular coronary perfusion occurs almost entirely during diastole. Cardiovascular physiology requires zero blind memorization once the mechanics are clear. The body simply applies mathematical laws to physical vessels to keep pressure constant and tissues alive.